T4 friends. It is Dr. Alana Bree. It is coming up on Thanksgiving season. And so I just want to start and say how thankful I am for the opportunity to be with you guys through T4, be with our T4 community. I want to give a big shout out to the Sages crew, the marketing crew, to Sydney and to Cindy and to all the rest in the marketing team at Sages, and just the support they've given, of course, to Dr. Davis, who helped me get started. And then, of course, to all of our T4 speakers that have made this year possible with all the great learning that we've had together. We've had some wonderful guest speakers, and we have a returning guest speaker, one of my faves, Dr. Agim. And she is coming to us with a really important topic tonight to discuss. So Hue-man Dermatology, because we're talking about skin colors and color and culture and conscious care of children's. Oh my gosh, it's a tongue twister. You didn't put all the C's. You know that I like alliterations, the T4, right? Color, culture, conscious care of childhood cutaneous complaints. Yay. I can't even say the title, but I've got to look, kind of preview the slides, and you guys are in for a major treat tonight. So I'm going to let Dr. Agim take it away. And again, happy Thanksgiving, everybody.
Happy Thanksgiving, everyone. Thank you so much for the invitation to speak to you about a topic that's near and dear to my heart. I love dermatology. I love taking care of children. I love seeing skin of color patients. And I want anyone who uh, listens to this lecture, who takes care of patients of skin of color, to do so with confidence. That's the purpose of this lecture. So skin is the largest organ that we have. And when you approach a patient, one of the first things you see about them is the color of their skin. The skin color is determined by many different factors, and it can play into how certain diagnoses present or how complications following certain dermatologic diseases may occur. So skin color is determined by our genetics and influenced by external factors like UV light. At its basics, there is something called the keratinocyte melanocyte unit, where one melanocyte makes packages of pigment that are dispersed to a certain number of keratinocytes throughout the skin. If there's any disruption in the number of melanocytes, the amount of melanin, the type of melanin that's produced, or the integrity of the keratinocytes, you can have changes in the pigmentation that you see in skin. And my goal is to talk about kind of the background of color in skin, and then talk about how common conditions that we see in children present in a child with skin of color. And then a little bit about how a treatment approach for any of these conditions may be adjusted or optimized to get the best outcomes for a patient with skin of color. So Kofi Annan used to be the president of the UN, or whatever the leader is called, and he has a lot of famous quotes, and one of them is this one, which is that all of us are part of the human race. You know, after they did the human genome, it's determined that we all are genetically similar, even though we have many variances, which contributes to our diversity, and I think enhances the beauty of humanity. And apart from all the external things that we think about and swirl around us in the world, at our basics, we're all human beings, and we're all trying to make it in life. We all want to, hopefully want to help each other. And seeing each other as we are, as we come, as we arrive, as we're created, is part of that process. So these are some conditions in a variety of skin tones in patients with skin of color. I mentioned that the color in our skin, I'm sorry, is determined by melanin. There are two main types of melanin that you can produce. Melanin that has a primarily brown hue is called pheomelanin. And then melanin that has melanin that has a primarily brown hue is called eumelanin. Melanin that has a reddish tone is pheomelanin. So the conditions that I have pictured here, just to go through them, the first is a patient that I saw with a linear array of skin-colored papules. And I like to say skin-colored. A lot of times people will say flesh-colored, and flesh is technically like your dermis, which is pink, which for some people, their skin might match their dermis, but not for everyone. But skin color is more general. There's no tying it to any particular person. You're using the patient as their own reference for that color that you're describing. So this patient has, skin-colored micropapules in linear array. And this was a patient that had lichen striatus. Below that is a hand showing lichenification and hyperpigmentation in a patient who has atopic dermatitis. The picture of the umbilicus shows an erythematous scaly plaque. The erythema is not as bright as you would expect in someone who may have lighter colored skin in the background, but this is a patient who has psoriasis. And then next door to that is a little boy who had vitiligo with depigmentation or loss of pigment all around the borders of his lips. Um, Above that is another child who has atopic dermatitis. His skin is acutely inflamed, but you don't see a lot of bright red erythema as you would expect as one of the usual descriptions for inflammation. He does have, however, a lot of hyperpigmentation, and in some of the plaques, a violaceous tone to the skin, indicating that there's actually active inflammation. This is not just chronic lichen sclerosus chronicus; it's actually flaring atopic dermatitis as well. And then in the middle is a little boy that is near and dear to my heart. This is my firstborn son when he was a baby, and I was a derm resident. He had infantile acne, which I did not treat and went away on his own. And, learning from my children's skin has also helped me reassure patients and families about what to expect over time, when to worry, when not to worry. So, whenever we're looking at a patient, we're processing many different things at the same time. Where we all have biases, and our biases inform our outlook. So, being aware of your biases and stopping yourself to reorganize or rethink is very important when you're looking at a patient. Because when you see them, you may make an assumption about, well, based on their skin tone that I see, I assume that they come from this neighborhood, and I assume that they have this amount of education, and I assume that they're not going to understand how I describe this diagnosis, or I assume that they're not going to be compliant. A lot of those things may bubble up to the surface at the same time, and you have to be willing to acknowledge that and then take a step back and say, how can I approach this patient, thinking about what may or may not be there. What questions can I ask to clarify what I'm assuming? And what can I learn from them? And then use that to give them better care. So, a little bit more about melanin. It's not just skin deep. Melanin is actually found, apart from in our skin, also in our brains, in our ears, in our eyes, and our adrenal glands. And melanin serves a very important function. It protects our skin from ultraviolet light. So people with melanin-rich skin have uh, larger melanin granules that are packaged or dispersed throughout many more keratinocytes because historically they've lived around the equator, and so they get the most amount of UV light and genetically and naturally have more protection against UV light. So we talked about pheomelanin being primarily brown and eumelanin being primarily red. And there are risks and benefits for each form of melanin. Nobody has 100% of one or 100% of the other. People have many variations based on all the ethnicities that play into their history. And then the skin color we see is actually also influenced by keratin and hemoglobin. Um, we talk about someone appearing pale, for example, when they're anemic. And that's because there's a reduction of hemoglobin in their skin. It has nothing to do with melanin, but you can tell when someone is quote unquote pale. And then we see babies who have carotenonemia. Some babies, when they start exploring solid food, love sweet potatoes or love carrots, and they eat lots and lots of those and develop more of an orange tone throughout their bodies, or sometimes more visible on their palms and soles. Both of those are things that you would approach differently. If they appear pale, you inquire as to if there's a reason why they would be anemic. If they have the carotenonemia, that's more of a reassurance. So culture is also part of what defines or what could play into what skin of color means. People with similarly toned skin are found throughout the entire world, but the cultures may vary. And so um, learning more about a patient may influence how you approach them. For example, if they come from a culture where typically they don't interact with same gender or different gender physicians, there may be a request from the family to see a particular person. It's not an affront to you or they're rejecting you, it's just that they're playing into what their cultural beliefs usually require. And we try to honor as much as what our patients need to feel comfortable, because most of them come to us in a vulnerable state. So some of the common conditions that are seen in skin of color, in the introduction, I talked about a few of them, but I want to go into a little bit more detail. One of the biggest ones is a complication, actually, that can follow many inflammatory skin conditions. This is post-inflammatory hyperpigmentation. It can be seen at any age, and it happens when there's a disruption in the keratinocytes that lets the melanin granules leak out, either into the superficial dermis or the deep dermis, and it can cause a stain in a pattern that mirrors what the original inciting inflammatory event was. Now, this is a very, very important factor, because a lot of patients, if you treat the primary problem and you don't address the post-inflammatory hyperpigmentation, they feel like the treatment didn't work at all. Even though you may see them back, like for example, with this patient and say, well, your acne is mostly better. All of these are macules. None of them are, nodules at this point. For this patient, their acne is not gone because they can see every spot left behind with the hyperpigmentation. It's very important when treating patients with skin of color, knowing that post-inflammatory hyperpigmentation is an important thing that no one really wants. That as you're choosing, for example, your topicals that you want to treat acne with, you're thinking about how can I treat your hyperpigmentation at the same time. So for example, you may use a topical retinoid, which is foundational for acne. Some topical retinoids do have studies backing their ability to improve hyperpigmentation. So you may want to select one of those. And then you may choose an agent like azelaic acid, which also reduces hyperpigmentation and treats acne. Sun protection is important regardless of skin tone. And you want to emphasize that, because one of the cultural myths is that the darker your skin is, the less you need to use sunscreen because you have quote unquote, natural sun protection. It's to some degree. Your natural sun protection is estimated around an SPF 12 with the darkest pigment in natural skin. And so it's usually not enough to prevent hyperpigmentation. When patients are selecting sunscreen, for example, this is another thing that can be touchy for some patients. Many sunscreens can leave a white cast on the skin. And so even though you're telling them, I want you to use sunscreen to prevent your hyperpigmentation, if the sunscreen is not pleasing in its appearance on their skin, they're not going to use it. And so you're not going to get the outcome you want. One of the things you can do to get around that is to have a variety of sunscreens that you try and you have available for your patients to try in the office if it's possible, because they can test it on their skin and see, okay, this fades away, or this is sheer, or this is transparent enough that I'm willing to put it on. And then they have the confidence to try that and then to use it and improve their outcomes for both the primary problem and for the hyperpigmentation that may follow. Another common condition that is seen in skin of color patients is traction alopecia. Part of the cultural identity for not just patients with skin of color, but people in general, is hairstyling. And some of the traditional hairstyles that are more commonly used in patients with skin of color do have the complication of traction alopecia. So cornrows, braids, plaits, twists, locks, all of those can put tension on the hair around the margins of the scalp. And initially, the hair loss is minor and grows back, minor and grows back. But the longer those high tension styles are repeated, you can move from a temporary inflammatory alopecia to a more permanent scarring type alopecia. So, you know, a lot of times if you walk into a room and say, I need you to stop braiding your hair so that your hair can grow back, a patient's gonna be like, I don't understand what you're saying to me, and you don't understand where I'm coming from. So it's very important to talk with the patients about um, how do you normally style your hair? What type of styles do you like better than others? What type of styles do other members of your family wear? Will your stylist be willing to loosen the tension on your braids? Would you be willing to change your braids more frequently so that the high tension is not in your scalp for a long time? There are a lot of conversations you can have that are different from just cut off what's naturally your style of choice so that your hair can grow back. But a lot of patients appreciate explaining to them why this is happening, and they're actually willing to make changes to improve their outcomes once they know that you understand the importance of the hairstyle to them, as well as being willing to help them with the hair loss. So here's molluscum contagiosum, a very common, very common skin condition that's infectious in nature. In patients with skin of color, sometimes the diagnosis is missed if it presents slightly differently. The little boy at the top has a giant molluscum on his eyelid. It has the same whitish hue that you would see in molluscum in any other skin type. The location is unusual, which is why initially it wasn't picked up. And then the child on the lower picture has molluscum that are inflamed, but the erythema is not as obvious as it would be in a patient who has lighter skin of color. The presence of inflammation can influence whether you choose to treat more or less aggressively to minimize complications, such as, again, dyspigmentation after your treatment. Um, Sometimes we use cryotherapy for molluscum, but if a patient has really dark pigment, cryotherapy can cause hypopigmentation. So you might want to pick a different treatment. And then uh, the treatments are the same regardless. Just think about how aggressively you would treat and what sequelae your treatment might result in order to get the best outcomes, both to get rid of the molluscum and not leave too much dyspigmentation behind. Trichorexis nodosa is another condition that has to do with the acquisition of brittle hair over time. Patients coming complaining that their hair doesn't grow past a certain length. They still have a full density of hair, and they're not shedding like you would see with telogen effluvium. This condition has been shown to be more common in patients with skin of color and curly hair, based on some of the styles, again, that put tension on the hair shaft and cause breaks in the hair shaft. This is a trichogram from a hair pull I did on a patient where you can see one of the splits in the hair shaft has what looks like the ends of a brush. There are little nodes that are formed where these areas of fragility within the hair shaft are formed, and the hair can break every time it's groomed at any of those nodes. This condition is sometimes spontaneously reversible. A lot of times you have to educate the patient to manage the amount of tension that they're using to style their hair. And then you can recommend supplements like L-arginine and vitamins to strengthen the hair shafts. Acne nucleoculoidalis is another condition that has to do with inflammation and also the structure of curly hair, which is more common in patients with skin of color. We see this more in teenagers. So when teenagers have to start grooming their hair, getting haircuts where they have fades in the back, or when they're trimming facial hair as well, the curly hair, when it's cut, has a sharp edge that can then incurve and pierce the skin and trigger a cycle of inflammation that eventually leads to scarring. So you want to educate your patients about how this forms, and if possible, and depending on the requirements at school or work or some of their extracurricular activities like ROTC, advocating where possible for them to be able to wear a longer hairstyle to break the cycle of acne nucleoculoidalis. Um, Athletic gear like football helmets can also play a role if they're placing pressure on certain parts of the scalp. This is a picture of a patient who um, was receiving laser hair removal for areas that he didn't want to grow hair anymore, and that kind of broke the cycle for him because the hair has to be there to cause the acne nucleoculoidalis. Tinea capitis is another condition that can be misdiagnosed at times. You don't want to miss seborrheic dermatitis. You don't want to miss psoriasis. You don't want to miss contact dermatitis, all of which can cause a scaly scalp. So I do love getting a PCR or a KOH or some other form of objective evidence for what I'm treating, so that I'm not treating someone with psoriasis with Grisea fulvin, or I'm not missing someone who has tinea assuming they have seborrheic dermatitis. A swab for PCR is high yield, or a swab for fungal culture can be high yield to inform treating our patients with exactly what they need for the condition that they have. And again, because patients with skin of color tend to wear hairstyles that last for a while, when we get braids or cornrows in, we're not washing our hair every week. We're going to wear that style for 4 weeks, 6 weeks, 8 weeks. And so when you're selecting a treatment, for example, that's topical, for instance, if it's seborrheic dermatitis or sebopsoriasis of the scalp and you want to treat with a leave-in topical, you want to consider, can that medication be used successfully by my patient with the style that they're wearing? You can ask them about how long they intend to wear the style, and you can actually tailor therapy to match how frequently they wash their hair and what texture of medication they want. For some patients, I mean, it's proven scientifically that curly hair is drier and has differences in the cuticle. And so a lot of alcohol-based solutions do damage the hair and can cause a lot of burning in the scalp. Medications that are in a form of an oil or an ointment are more friendly to curly hair and patients with skin of color. And so, where possible, if you have to use a topical medication for the scalp, you want to select one of those. And then again, for shampooing, ask about shampooing frequency and have your patient use a medicated shampoo at the frequency at which they normally wash. Because a lot of times, if you tell them to do it more frequently, they're not going to, and you both of you will not get what you want out of that therapeutic relationship. So keloids are another common condition that we see both in children and adults. There's a lot of studies going on looking into the origins of keloids. So far, they seem to be polygenic. They do run with other conditions such as uterine leiomyomas and hypertension. And this is a significantly disfiguring and concerning condition in patients, any patient who has keloids, but they're more common in patients with skin of color. Keloids are caused by trauma. Keloids are caused by piercing. There are a lot of piercing styles that are more common in patients with skin of color. And so you want to educate patients both about what keloids are, and about treatments that are available, and about how you're going to be treating over a while. But you want to educate the family as well, because oftentimes if there's a younger sibling who's thinking about getting a particular piercing, since we know that the tendency to keloid runs in families, it might be important for them to make a decision early as to whether or not they want to pierce. Interestingly, if a child gets a piercing before age 1, they don't make keloids, regardless of their genetic background. And we think it's because the types of collagen that are predominant in an infant evolve over time, not in favor of keloids. And so for some cultures like I'm originally Nigerian, in my culture, baby girls are pierced right when they're born. And we rarely see anyone have keloids. But if they get a second piercing after puberty, even people who had no keloids with their first piercing will do so. So it's an important conversation to have with your patients. Atopic dermatitis, we touched on this. I have patients here with 3 different skin tones. All of them are patients with skin of color. But we talk about, if you use the reference of Fitzpatrick phototypes 1 through 6, a patient who is closer to a 4, you can see the erythema in their skin as bright red. A patient who's closer to a 5 or 6, you're starting to see a darker red hue in the area that's on the cheek for the child in the middle that's acutely inflamed. And for the little boy I showed earlier, who's also inflamed, you don't see the same type of erythema, even though his lesions are active. So in this patient, you want to palpate the lesions. The ones that are active are usually more elevated, and they're usually warmer, the other things that you would see with inflammation. But sometimes the intense hyperpigmentation that you're seeing at these sites is the indication of acuity equivalent to the erythema you would see in a lighter skinned patient. Apart from hyperpigmentation, hypopigmentation is likewise distressing to patients with skin of color. And this is because there's usually a sharp contrast between affected and unaffected skin. I've seen times where patients, for example, who have type 1 or 2 skin, if they have vitiligo that's only detectable by the Woods lamp, they choose not to treat because nobody can see it. But for a patient who's type 4, 5, 6, it's very obvious even if they have one spot. And so it's very distressing, regardless of what you may think the amount of body surface area involved is. There's a fear of vitiligo in many cultures. And so sometimes when patients have pityriasis alba, there's concern that that is vitiligo. And so educating patients in the difference between the two and treating whichever one is present is very important. A Woods lamp is a key tool that we have in our offices. And when you pull that out and look at a patient's skin, if they have vitiligo, the areas of depigmentation are more enhanced. If they have hypopigmentation as seen in pityriasis alba, you don't see that, and you can reassure a family that, this is not vitiligo we're dealing with. A lot of times pityriasis alba is seen more commonly in the summertime because the normal skin will tan more than the skin that's affected, and then it's even more distressing. But again, you can help a patient distinguish between what condition is present, and then you both have successful treatments that we can use, and it can be addressed for the patient. Seborrheic dermatitis is another condition that can present differently based on the patient's background skin color. I have here 2 pictures, one of a patient with type 1-2 skin who's showing the classic salmon red bright erythema in skin folds. And because this is a form of generalized infantile seborrheic dermatitis, there's also involvement of the trunk. By contrast, the patient in the bottom photo may present primarily with hypopigmentation without significant erythema present, but these are the 2 examples of the exact same condition. The hypopigmentation may persist much longer than any acute inflammation. And again, like with vitiligo and pityriasis alba, can be very distressing, but it's temporary. So you can reassure a family that the yeast that is associated with seborrheic dermatitis creates azelaic acid and causes, hypopigmentation. But as you treat and control the yeast with a topical azole, for example, the hypopigmentation eventually will correct. And then acne. Acne, I mean, this is a classic dermatologic condition. It can be seen in babies, it can be seen in teenagers. Comedonal acne is usually skin-colored papules. More inflammatory acne will feature erythema, pustules, nodules, and everything you're seeing, including the comedones, can cause hyperpigmentation. So you want to treat patients with skin of color as aggressively as you can, even when the acne seems minor, because it's going to cause hyperpigmentation that's even more distressing. However, I say that with a caveat because if you irritate the skin too much with your choice of therapy, that irritation from the products you're putting on can also cause hyperpigmentation. So you want to choose the simplest formulas. You want to discourage patients from using excessive exfoliation, like when they're on a retinoid, they don't need to use a toner, for example, because the toner may make sense or be popular on social media, but all it's doing is creating extra irritation that will yield additional hyperpigmentation, which is much harder to treat or lasts longer than the primary process. There are some findings in skin that are completely normal for patients with skin of color. And sometimes you may be referred to see these patients with concern that they have, an atypical condition. So you should be aware of normal variance in skin pigment in patients with skin of color. So lines of fusion of the skin sections that are formed in the embryo may have hypopigmentation. They're called Futcher's lines. They're called pigmentary demarcation lines. These lines may be hyperpigmented or hypopigmented and are typically seen along the center of the body, or as you can see on the limbs, splitting down the bilateral medial portion of the body. But these are completely normal. It's not vitiligo, it's not post-inflammatory, and no treatment is necessary other than sun protection to reduce the contrast. Um, Here, I wanted to show an example of a diagnosis that looks different based on, again, on the background skin tone of the patient. So the patient on the left and the patient in the middle, the patient on the right as well, all have cafe au lait macules. Um, but looking at the middle picture and the one on the left, the cafe au lait macule is much darker in a patient with darker skin than it is in a patient with medium toned skin. And so sometimes people are thrown off by the degree of pigment. Is it still a cafe au lait macule or is it a nevus? But you want to keep in mind reading the tone of some of these birthmarks based on the background skin of color patients. The same thing you may see with mastocytomas as well. They're classically red-brown, but that's based on someone who has type 3 or 4 skin. In darker skin patients, a mastocytoma is going to be dark brown. You can perform the Darius sign on either tone and get the same response, but you want to again read the lesion you're seeing through the lens of their background tone. Moving from nevite to melanoma. Melanoma is rarer in patients with skin of color, but not impossible. These are 3 cases of melanomas that I've seen in my career in patients with skin of color. The top one was a little boy who noticed a spot on his foot in the shower and thought he had stepped on something, but when it wouldn't heal, they came in and a biopsy showed that it was melanoma. And then the bottom one that's a dermoscopy picture was a girl who had a spot on her wrist and was seen in the ED, and they thought it was a wart initially, but then when it kept growing, they came in to see us, and we took it off, and it was a melanoma. And then the baby has a giant congenital melanocytic nevus, which carries risk for melanoma, and in this child, unfortunately, that malignant degeneration occurred. So even though you may assume that something is unlikely in a patient with skin of color, if the history and the clinical features suggest otherwise, allow yourself to explore that. Allow yourself to say, even though this may not usually happen in this skin type, let me just make sure it is or it isn't, with a biopsy, with imaging, with whatever it is necessary to properly evaluate that patient. And then melanonychia. So this condition is more common in patients with skin of color. We know that when melanonychia can be distressing when it's in 1 digit because the concern is for having a subungual melanoma. In patients with skin of color, it's been estimated that about 2.5% of patients under 4 already have at least 1 nail that's involved, and the number of nails involved increases over time. The fingernails are usually involved more so than the toenails, and trauma can induce longitudinal melanonychia. It's typically more common in the thumbs and first 2 digits, and it's sometimes seen on the 5th toe at the great toe, where shoes can apply some pressure to the feet. The nail plate is usually normal, unless, as in this case, the patient is picking at the nail. But even this patient does not have a Hutchinson sign, which would be concerning for a melanoma. Longitudinal melanoma, however, can also be seen with conditions like Addison's disease. So if a patient, even if their skin of color has a sudden change in their overall pigment, in the pigmentation of their mucosa, and in the pigmentation of their nails, allow yourself to explore whether they have a reason for a sudden change. At baseline, like I said, melanoma is common in patients with skin of color. But if someone comes in, which I've had happen, saying, I had a mom come in saying, a child's been tired, he's not playing soccer, which he loves, and he just got darker. He used to be same tone as me, but all of a sudden he's darker. And now what are all these lines on his nails? So for him, at first glance, this is quote unquote a normal or common finding. But taking the history together with the findings and then screening with lab work, he was identified to have Addison's disease, which is treated by endocrinology. So consider the common things, consider the history, take all the different parts of the puzzle, and decide if you're dealing with just the common things or if you should look further in spite of it being normally common in a patient with skin of color. And then psoriasis, the lighter the skin tone of a patient with psoriasis, the more likely their plaques will be the classic erythematous plaques with silvery scale. But if you have darker patients, a lot of times their diagnosis may be missed because they come in with hyperpigmented plaques and their scale is not necessarily silvery. So if you see a patient with plaques that are not responding for treatment, for example, for atopic dermatitis, and are not going away, and they look like psoriasis, but you're not sure, if you have to perform a biopsy, perform a biopsy to prove it so the patient gets the right treatment. And we now understand psoriasis is not usually an isolated disease. Even in children, even in teenagers, you have to inquire about joint pain to entertain the idea of psoriatic arthritis or inflammatory bowel disease, because those can make both psoriasis, they occur more frequently with psoriasis, but your choice of treatment for psoriasis may make one of those things better or worse. And often it helps you work in conjunction with rheumatology or GI in taking care of your patient. So everything I've talked about, my goal again is for you to not put everyone into the same mold the moment you see them. That's our natural response when we see someone. It's like, I assume I know this much about you, but I want you to give yourself a moment of pause internally and ask, what am I assuming? What do I actually know? And what can I ask about? A lot of times patients may not volunteer information to you in the tension of a clinic visit. But if you ask, they actually appreciate and may give you more information that helps you take care of them better, and that helps you select choices that give them better outcomes, and you learn from them. So I encourage you to be curious. I encourage you to be creative with your approaches to treating patients based on what they give you. I encourage you to request feedback because you learn from them what works, what doesn't work, and it can help you help the next patient better. So I want to end with this quote saying that, when we recognize each of us as being uniquely human, we're actually paying tribute to ourselves because we're human too, and we want to be treated the same way we're trying to treat our patients. I want you to render care for patients with skin of color, and indeed all of your patients, because we all have color in our skin, just different types. And let, when necessary, what you're seeing based on the patient's skin of color or the background skin of color and the lesion that you're seeing be your clue to take better care of them. Thank you.
Oh my goodness, Dr. Agim, you blow me away every time. What a great talk. What an amazing talk. Thank you, thank you, thank you.
Thank you.
I always learn from you, and this was no different. I think, all of the things you brought up are so pertinent. And again, one of my favorite sayings is, you don't know what you don't know. And when we make assumptions, again, the long time saying of what do we do out of you and me? So let's not do that. And again, the quotes were amazing. I love that. And I do think it takes humility to see humanity. And, in dermatology, pattern recognition is helpful, but patterns are going to look different with different skin types and skin colors. So again, it can't just be a pattern recognition game, because then you're going to miss things. So again, remembering the hues of humanity
Mhm.
are very important. And I'm glad that this has come to light. And I'm glad for all of the changes that are happening in the dermatology world and the skin of color world. And again, we're all skin of color. Um,
Yeah.
but the darker skin types are really being brought to the forefront. And I love that. And I will champion that alongside of you. And yes, and I love and again, it is, we have these assumptions, again, those unconscious biases that are unconscious. So we're not going to recognize them unless we have these conversations. So they're so important. And again, I don't say flesh colored, I always say skin colored, but I didn't even think of that just minor shift between flesh color and skin color. And then again, you know, I do think it's really important to ask about the skincare habits of our patients. We should be doing that regardless. So again, bringing in the discussion, especially with different hair types. And again, I've learned from my patients over time, asking how often they're going to have a hairstyle or how often they do shampoo, that can really inform care. And then everybody has a vehicle preference, really. And if you
Yeah.
don't know what that vehicle preference is, you need to be talking about those things regardless of the patient's skin type, but especially with skin of color, because it may be different. What works for me is going to be something different that works for you, clearly. So, yeah, just so much good stuff. And then I'm going to admit my ignorance. All right. I might even blush just a little bit, but I did not know, or maybe I knew and forgot, but malassezia makes azelaic acid?
Yes.
Did I?
That's how it makes the hyperpigmentation. Yeah.
I
Yeah.
did it. I swear. And I probably can go back to a textbook and go see that I highlighted it at some point in my
Yeah.
lifetime. But that was news to me today. So thank you. That sounds like a good board question.
Yeah. Yeah. And like one of the things I learned from my patients, and I kept thinking about, I kept seeing patients who had a lot of follicular eczema or lichen spinosus that was chemnorizing everywhere. And one of the questions I started asking patients was, how do you like to bathe? Knowing that in my culture, we use a net sponge or a loofah to scrub the skin. And for a lot of those patients, they were chemnorizing their molluscum, their warts, whatever, because they were scrubbing their skin as usual, just out of habit. And so for a lot of them, just saying, hey, I know do you normally use this in the shower? Maybe you shouldn't. And a lot of their problems got better because they changed what they was their normal, just because they had whatever condition required that.
Yeah, and that's so important. Just like applying your creams and your ointments too. Like I had a patient that, kept going to ID and kept having all these skin infections. And it was basically their tub of triamcinolone, which I didn't prescribe, that they had from years ago from another dermatologist that they've been dipping into, was a petri dish. And they
Mhm.
cultured the skin and cultured the tack. And guess what? It grew the same
Yep.
strain.
Yeah.
And again, unless you ask your patients those very specific questions,
Yeah.
you're not going to get the answers that are always helpful. So again, really diving into their skincare routine and all of the products they're using over the counter, what their routine is. And that includes how they're applying it, how, again, very specific. So I think that only, can help care when you know all the details. Um,
Yes.
so yeah, important part there. And then, gosh, there was one more point that you brought up. Just, I guess, cultures. I think that's important too. It's so easy just to grab a culturette. It doesn't cost a lot of money. And with a fungal culture, if I have anybody, regardless, with hair loss, unless I am 100% specific, like,
Mhm.
sure, I guess, that it is a certain condition, for the most part, I would swab everybody and send it off to the lab,
Yeah.
treat with what I thought was the most appropriate. And then when they follow up in 8 weeks, you have your culture back. And then if things aren't working, if the culture is negative, and it just informs the next steps. And
Yes.
do you just need to
Yes, it
increase
does.
treatment, or do you need to actually totally change course? So, and
Yes.
I've been surprised on both sides,
Yes.
where I thought it was fungal and it was negative when it comes back, and where
Mhm.
I thought it was going to be negative and it's positive. And, I had given a topical steroid empirically when I first grabbed the culture. So I think we, as dermatologists, are so lucky to have bedside tests that we can still access, as far as doing a KOH, getting a culture,
Mhm.
doing a zinc, doing a gram stain, doing a trichogram. So yeah, that also, that's what I wanted to ask. How do you do your trichograms in clinic? Because again, it's a quick, easy procedure to do. And to pull a few hairs in clinic, you can always
Yeah.
send them off to the lab, to sage us, of course,
Yeah. Yeah.
if you need to,
Yeah.
or any other
But you can do it very
dermatopathologist
quick,
of your
and patients
choice.
appreciate that because you can diagnose telogen effluvium, you can diagnose loose Anchin syndrome, you can diagnose hair shaft disorders. Even like I think we picked up like a banded hair, So what I do is I take two microscope slides. I ask permission, and then as I'm talking to the patient, I just try and tug close. I grab close to the root of the hair and try and tug and take what comes. And then I place the hairs. I try to align all the roots in one direction. I place it on the first slide and tape down the bottom, and then use the second slide to create a mount and then seal it again with tape, then go look at it under the microscope.
Perfect. That's a great way to do it. That's a great way with the tape. I wish you would have taught me that when way back when you were, because I'm always struggling to get them to lay down and not, yeah. And sometimes,
Yeah, so if you grab them and then once I have them aligned, I'll like twist them once. It
yep.
brings them all together, and then that twisted portion I'll tape to the matte part of the slide. And then you can use the second to like align any of like especially when it's curly, to pull any like and slide that into a flat, one piece and then tape that again.
See, look at that. That is some firsthand practical knowledge, T4 community right there. Bam. Yeah, so you can sometimes use mineral oil. Like I've read you can use mineral oil. So I've tried that. That's messy. And I
Yeah,
find it gets on the object, the lens and all that, and
yeah.
then you can't see.
So the dry
Um,
mount is good, and then the weight of the second slide is better than a cover slip.
yeah.
So yeah, the dry mount is it's been really helpful.
Yeah, no, I love that. I love that technique. Thank you for sharing. Thank you for teaching me. All right. Well, that was all my questions. Anybody in our T4 community, does anyone have any questions? I don't see any in the chat. So, I think that we are all set to wrap up this T4, this amazing T4. And thank you. This is the last one of the year for you, Dr. Agim. Thank you for
Oh,
being such a
thank
regular participant. It's been so good to learn from you and alongside you. And I know that everybody that views this lecture is going to learn so much. So thank you. I
thank
am
you so
very
much.
thankful for you. Happy Thanksgiving.
I'm very thankful for you too, for all of your team. You guys are always so gracious. I'm really grateful. Thank you so much. Happy Thanksgiving.
All right. Bye, guys.
Bye.